Good morning, ladies and gentlemen. I'm sure after the last night's good dinner and then, of course, had a good sleep and morning breakfast, you are in a mood to listen to shock in acute myocardial infarction. What is the definition of cardiogenic shock? All of us know about it, but few points I would like to stress. It is a sustained low blood pressure less than 90 millimeters. But the caveat is that it has to be more than 30 minutes. Or if the patient is on some supports like dopamine, dobutamine, norepinephrine or epinephrine, or the patient is on an intra-aortic balloon pump, then the 30 minutes caveat does not hold true. Or if the patient has had an hemodynamic monitoring, cardiac index less than 2.2 liters per minute per meter square body surface is a sign of the objective sign of a cardiogenic shock. Then of course there are signs of hypoperfusion like low urine output, or this has to happen in the face or in a situation of an adequate left ventricular filling pressure. Because if there is no adequate left ventricular filling pressure, then it is not a true cardiogenic shock, then it is a hypovolemic shock. So I think one has to differentiate between a true cardiogenic shock due to loss of myocardium versus a hypovolemic shock. Even till today, after the institution of the thrombolytic treatment in the cardiology practice, still we time and again keep on seeing cardiogenic shock in acute myocardial infarction. Even till today, it accounts for 5 to 7% of all AMIs. It's loss of more than 40% left ventricular muscle. Now, this loss of left ventricular muscle could be either at one shot, the patient develop a massive infarct due to a very large dominant left anterior descending artery or a left main coronary artery block, or it could be a cumulative one, like for example, at some time patient had a lateral wall infarct, which lost about 10%, second time another 10%, third time 40%. So it could be either one time shot, that is loss of myocardium, or it could be a cumulative loss due to repeated myocardial infarction. There could be mechanical defects like mitral regurgitation, ventricular septal defect, cardiac tamponade or left ventricular rupture, right ventricular infarction with a large inferior myocardial infarction is a common occurrence, as Dr. Sudhir Vaishnav has already spoke to you. In such cases, if the patient has been in the bed for a long time, there could be a pulmonary embolism associated with could be hypovolemia, or the presence of arrhythmias like ventricular tachycardia, ventricular fibrillation could precipitate cardiogenic shock. Out of all this, last 7 ones are not the true myocardial loss, not the true cardiogenic shock. They are due to mechanical defects. What we mean by a true cardiogenic shock when you've got a loss of more than 40% of the left ventricular muscle. Rest of them are all due to some mechanical cause which are surgically treatable. Is usually multivessel disease, complex anatomy. There's usually a large thrombus burden. Therefore, the effect of thrombolytic agents is very unpredictable. More than that, because the vessels are collapsed, the thrombolytic agents do not really reach the place where it's supposed to reach. And the hypotension and extensive microvascular damage is sort of accounts for a lot of morbidity and mortality, because even if you opened up the large epicardial vessel by angioplasty, you may not get the adequate results. It's absolutely misconceived idea or belief in the minds of the people that it is the anterior wall infarction only which causes a cardiogenic shock. As a matter of fact, if you see from Gusto trial, anterior as well as inferior wall infarctions are equally responsible for causing a cardiogenic shock. So don't expect that the patient who has only inferior wall infarction will not have a cardiogenic shock. Either one of them could be responsible for a cardiogenic shock. For example, here's a patient who has a total right coronary artery occlusion, had an inferior wall infarction, Because of the presence of the critical left main stenosis, the left anterior artery disease, which is a very critical lesion, the patient presented with a cardiogenic shock. What are the strategies for managing a patient with a cardiogenic shock? The most important and the most useful one is the emergency revascularization, either by PTCA, that is PCI, or by coronary artery bypass graft surgery, about which we'll talk in the next course of next few slides. The initial management, all of you know, because most of you work in your own community hospitals or nursing homes, where you are used to initially stabilizing the patients with the volume, with the appropriate dose of dopamine, Witrex, or the epinephrine or norepinephrine. I don't want to get into the details because levosimendan has already been discussed earlier. What I want to stress upon, that when you do this initial medical stabilization with fibrinolytics, inotropes, you are delaying an emergency revascularization in these patients. And what is the data to suggest that do not delay this emergency revascularization in the patients of cardiogenic shock? I'll show you some data that the time is of great essence in managing a patient of cardiogenic shock. So while you're trying to stabilize the patient, please go ahead and make arrangements for transferring a patient to the primary primary PCI center or to the center which is very good for performing an emergency coronary angioplasty or emergency coronary artery bypass graft surgery. So you may go ahead and do this, but never ever delay this revascularization procedure in these patients. What are the classifications? All of you are well aware of it. The age-old classification is called as a CLIP classification, class 1, class 2, class 3, and class 4, depending upon the hemodynamic state of the patient on the clinical signs, bedside signs. And you can see here, the mortality is directly proportionate to the type of class, CLIP class that you see. In class 1 is 6%, class 2 is 17%, class 3 is 38%. And when a patient presents with cardiogenic shock, close to 80% patients die. As a matter of fact, in the past, before the era of revascularization, people used to say, if your patient has, your group of patients does not have 100% mortality, then your definition of cardiogenic shock is wrong. Because in those days, when there was no coronary artery bypass graft surgery available, no PCI was available, mortality was close to 100%. There is a Cedars-Sinai classification, which is a hemodynamic classification, which actually goes pari passu with the clinical classification, which takes into account the pulmonary artery capillary wedge pressure and the cardiac index. The lower the cardiac index and higher the pulmonary artery capillary wedge pressure, higher is the mortality. So it is actually 1:1 relation. Only thing is that it accurately gives us the bedside hemodynamic monitoring by which you can judge the ultimate prognosis in a given patient. Now let us look at what is the revascularization data available to us. We have a very famous trial called as the shock registry trial or a shock randomized trial. In the registry, 884 patients with 36 multinational centers, and about majority of them had a multivessel disease. What they came to the conclusion that the aggressive medical treatment mortality was 46%, aggressive medical treatment mortality was close to 78%, and the aggressive treatment with the revascularization was 46%. Very important was that the mortality was directly related to the completeness of the reperfusion and also the TIMI grade 3 flow. The mortality was lower when you had a low TIMI flows, like mortality in 0 and 1 was 85%. And look at the hours, and this is what I was trying to tell you, that if you perform a PTCA in less than 18 hours, the mortality was lower as compared to the no revascularization group. And when the patients were sent for coronary artery bypass graft surgery in less than 18 hours time, again the mortality was lower as compared to the no revascularization group. Very important data came out that between the two strategies of the revascularization, apparently it looks that the coronary artery bypass graft surgery gave better results than the PTCA. The reason being that here possibly we were able to in the past, able to do more complete revascularization with surgery than with the PCI. And then same thing was in the randomized trial, shock randomized trial. And very important data which came out from this, that when you looked at you stratified your patients according to the age group, those patients who were less than 75 years had a much better results of aggressive revascularization strategy than the medical treatment. However, patients who were more than 75 years, they did not do as well. So ladies and gentlemen, what is the next strategy that one can do? The next strategy is to supply the more blood to these patients and reduce the left ventricular load. As you know, the supply depends upon coronary artery anatomy, diastolic pressure, because coronary arteries get filled up during the diastole, and demand depends upon the heart rate and the preload. And this one can do with an intra-aortic balloon pump, which is put in distal to the origin of the subclavian artery. It gets inflated during the diastole, deflated during the systole. This is the correct position in which the balloon is kept, and the inflation occurs at the dicrotic notch and gives a diastolic augmentation to the patients. Now when one should deploy or use the intra-aortic balloon pump, it is better to use before the really patient gets into the cardiogenic shock. As a matter of fact, the ACC-AHA guidelines considered intra-aortic balloon pump in cardiogenic shock as a class 1 indication. A very latest kind of form of treatment, called a device-oriented treatment, is called as the impeller device, which is put where the catheter is put into the left ventricle. The catheter distally unloads the left ventricle and reduces the work load on the left ventricle, and the blood is again injected back into the aorta, maintaining the circulation to the body and to the brachiocephalic circulation. And finally, what happens to the patients who recover from shock? It's very surprising. Though the initial mortality is very low, very high, but if you see over a period of next 10 years, they remain very stable. So the message is that manage your patients' shock very well. If you manage them very well, you get them out, over the period of 10 years, they will do in a flat curve like this, as much as those patients who had no cardiogenic shock. And therefore, ladies and gentlemen, to conclude, the ACC-AHA guideline consider cardiogenic shock for revascularization, emergency revascularization, as a class 1 recommendation. Thank you very much.